You are in the ladies' room with Dr. Donnica, the only public ladies' room you can enter anytime without ever waiting online. I'm your host, Dr. Donnica Moore. We'll be having real conversations with real women about really intimate issues. They may be embarrassing, sad, or funny, but they will always be interesting and informative. You know, like the best conversations you've had in ladies' rooms with your best friends, or total strangers and a physician. Please join us. Hello, and welcome to another exciting episode of In the Ladies' Room. You will not believe who's with me today. Kamala. No, not that Kamala, not Kamala Harris. But since it's still Women in Medicine Month, we're talking with super doc, Dr. Kamala Tamirisa. She's a cardiologist, super specialist in cardiac electrophysiology and advanced cardiac imaging at Texas Cardiac Arrhythmia. And yes, I will ask her to explain to us what that is and what that involves. Dr. Tamirisa completed her training in internal medicine and served as chief resident at St. Louis University in Missouri. She then completed General Cardiology, Cardiac Electrophysiology, and Cardiac MRI fellowships at the University of Michigan. She subsequently joined a large cardiology group called ProMedica Physicians Cardiology in Ohio, where she served as the director of the Arrhythmia Clinic, ProMedica Heart Institute board member, and director of education affiliated with the University of Toledo. And of course, she was maintaining a large, busy practice all at the same time. She's received numerous awards for her work, including the Healthcare Heroes Award for Northwest Ohio for making a great impact on community well-being and health. Her passions revolve around gender equity, both in and out of medicine, curbing disparities in healthcare, and physician well-being. She's a strong advocate for the physician-patient relationship and to bring medicine back to science, empathy, and clinical skill, and away from corporate and revenue-driven healthcare systems. Dr. Tamirisa, welcome to the Ladies' Room. Thank you for coming.
Thank you so much for having me.
Oh, it is
and I'm
great.
Excited. Yes, excited to be here.
Yay, it's great to see you. And I know you must be getting these jokes about, your name and Kamala, all the time now. And I'm sorry to have been a cliche, but how do you feel about that?
I love it. Now, no more I am a Camila. I am not a camel.
Oh, okay.
I am Kamala, and I love it.
But it's spelled the same way.
Spelled the same way and pronounced pretty much the same way.
So we've heard from, lots of women and girls, during this time about how awesome it is to have a candidate, a major party candidate who looks like them. But now you have one who has the same name. And I remember how excited I was, years ago when Geraldine Ferraro ran for vice president and how exciting that was.
Yes, absolutely. This is the most fun time, apart from, I don't want this to be a political discussion, but it's absolutely fun where I don't have to clarify the way to pronounce my name anymore. And just the other day, a vascular surgeon joined the healthcare system, and he walked up to me, and for the first time, I didn't have to pronounce my name or correct him. He said, "Oh my God, I know how to pronounce your name." And today, just this was a month ago, every time we meet in the elevator or near the OR, he passes a comment saying, "Hi, Kamala, how are you?" Oh.
Well, and you have Maya Rudolph on Saturday Night Live teaching everyone how to say your name. I know that as somebody whose name is Donnica, which is very foreign sounding and unusual to most people, I do spend a lot of my time telling people how to pronounce my name and the origin and the etiology. And I can't imagine what it would feel like to have somebody running for vice president who had the same name as me. Now, it seems like, this is a very exciting time in many ways, but of course, we're still in the midst of a global pandemic, which does not seem to be waning at all. So I just want to start off by saying, asking, how are you and your family doing?
We're doing so far so good, just like everyone else, trying to make the best out of the situation. The way I look at life is you can't change what's thrown at you. Mm-hmm. Just think like you're the quarterback, field. You just catch the ball, throw the best you can, and hope the person across you, including my family members or my colleagues or the community around me, catches that ball, and hopefully we make it to the touchdown.
Right. I think one of the things I tell my kids all the time is it doesn't matter how many times you fall down. It matters, how you get up. And, so
Absolutely.
we have to find strategies to deal with that. My son did have coronavirus in the very beginning,
Wow.
but fortunately I was able to care for him at home and nobody else, caught it from him. So I can tell everybody with assurance, if you practice the proper precautions, you can actually, manage this. But of course, for 200,000 families, that advice is, way too late.
Oh, and I belong to that. One of our close friends, he's my uncle and more of a mentor. I lost him during the pandemic
I'm so sorry.
to COVID in New Jersey. So that has been hard, and we lost him in April. So
I'm
I
so
can
sorry.
totally relate to that.
We were hit very hard here in March and April in New Jersey. But how did it affect your practice?
Our practice, we switched over to telemedicine instead of seeing patients in the clinic. And telemedicine, initially we took that with a little skepticism, without being able to examine a patient and interview a patient, by being in close contact. But over time, just like we humans try to adapt to everything, we adapted to the telemedicine. And I can tell you, the older patients love it because of lack of commute. It takes away the commute time, the pressure, and even the younger patients take time out of their work and are able to make those appointments. So we are making the best use of telemedicine. Cardiac electrophysiology as a profession, we are very dependent on elective cases. So the number of cases or procedures that are not emergent had to be put on hold because of the pandemic. But slowly we are able to get the patients back to take care of them.
So explain to people what cardiac electrophysiology is.
Cardiac electrophysiology is a very long word for a simple cardiac health issue. I usually tell patients, think of the heart like a home. A home has walls, the doors, the plumbing system, and the electrical system. And cardiac electrophysiology is the electrician of the heart. And the cardiac interventionalist, if they come across that name, those are the plumbers. So what do I deal with?
I'm sure they're loving that description.
So what do I deal with? I deal with the electrical system of the heart where I do procedures called ablation procedures using radio waves to take care of extra nerves in the heart to treat atrial fibrillation, which is one of the commonest rhythms, and extra nerve in the heart that people are born with, or I put in pacemakers for slow heartbeats or defibrillators as shock boxes to protect people's lives. And so those are the procedures we do, and it's a very gratifying field.
So explain to people, one of the things that I've heard a lot of people talking about, especially since I actually had a brother who had triple bypass surgery right before the pandemic, and he actually did need an implantable defibrillator put in, but they postponed it for quite some time. And I think one of the things that was very confusing to his family members and lots of other people I've talked to is how that's elective. Because if we're saying that somebody's heart rhythm is abnormal, and that's all an arrhythmia is something abnormal in the electrical system, certainly we wouldn't keep something abnormal in the electrical system in our house without being taken care of right away. So how is that elective?
Yes, and the Heart Rhythm Society and we as EP physicians, we debated about this very topic. What is defined as elective and what is not an elective? And actually guidelines were passed. I get it, it's a fluid state. So when you pass a guideline, nothing is concrete because the pandemic keeps changing. But putting in defibrillators in patients like your brother, that in our practice, we didn't define that as elective. So there was a lot of variability across practices across the country, and that probably because of, number one, did that particular area get hit hard with COVID? How many COVID patients have you had? What's your bed capacity or OR capacity to take care of patients safely? And also, different types of hospitals. For example, our hospital is a purely cardiac hospital. So I did not see that many COVID patients. We didn't have that many COVID patients. So in our practice, I took care of all these defibrillator patients, didn't define them as elective, and took care of them.
So in his case, he was at Stanford in, California, outside of San Francisco, at a time when they were really, really hard hit. And I did speak to his cardiologist, and what she told me is that they just didn't have adequate personal protective equipment for the providers, not just the physicians, but also, all of the other personnel who are in the area. And they were not exclusively a cardiology hospital.
Yes.
They were also worried that they didn't have any available ICU beds in case there was a problem.
Yes. And I totally agree. The PPE shortage really hit us hard, even in our practice. We worked at it. Our healthcare system supported it, but we had that fear. We had the fear that we would not be protected, and we had the fear that we cannot effectively protect our patients without COVID. So there were a lot of variable elements that we as physicians, as you know, had to fight through this pandemic to safely take care of our patients.
So what drew you to become, I want to ask you what drew you to become a cardiac electrician, but originally, what drew you to go into medicine in the first place?
I am the first physician in the family, so against my father's wishes and everyone's wishes in the family, I literally went into medicine. To give you an anecdote, my whole family, by the way, is filled with PhDs and engineers. They are in AI, electronics, computers, and my sister is a professor in artificial intelligence. She trained at Carnegie Mellon, and she's a professor now. So now taking back the discussion to me, I wanted to go into medicine because there's something about the heart that drew me to cardiology. I knew probably in middle school that I would go into cardiology and I would become a cardiothoracic surgeon or do procedures on the heart.
Wow.
And for lack of a better word, I think it was a calling. There were no mentors. I didn't see any cardiologists. No one in the family had cardiac disease to get me there. But once I went into medical school, my dad literally walked up. He, against the doors and everything, he opened the doors. Somehow an engineer makes into anatomy lab, stands outside the door and tells my anatomy professor that his daughter does not belong in medicine.
Oh my gosh.
And to this day, my dad always says, why did you go into medicine? Engineering is so much more fun. Now, I know it's funny. So I literally had to tell him, no, I want to do this. And I think the fear in him.
How did your professor react?
My professor, he pulled me aside and he just said, your father is very worried about you going into medicine. Are you sure you want to do this? I said, 100%. I know what I want. I'm a very driven person. And
I've heard of lots of parents who objected to their children going into medicine, but not to the point where they walked into anatomy lab and spoke to the professor.
Yeah,
that had to have been a first and kind of humiliating and embarrassing.
Yes. To this day, we talk about it, my dad and I, and I think, back of his mind, now he tells me he didn't want me to go into medicine because of the work-life balance or integration, that he was concerned that I wouldn't have kids or have a family. And because he has heard from many friends that they had, marital issues or stress balancing both, and he was being a parent, a pushy parent. I still love him though.
An interventionist parent. But it was interesting that he didn't even give up once you already started medical school.
Yes.
So you went through the whole process, and then he still, was trying to intervene. But obviously I know, but our listeners don't know, that you did go on to have a family. So where did you have your children in relationship to your training and your career?
So I had my children towards the end of my EP fellowship, cardiac electrophysiology fellowship. I have two boys. I have a 11-year-old, soon to be a 12, and I have a teenager who thinks is an adult. And I love both my boys, and I'm married to an interventional cardiologist, the plumber of the heart.
So how does he feel about you referring to his job as being a plumber?
We joke about it, and at some points we try not to bring work home. We try not to discuss patient care at home as much as we can. But in medicine, I always tell people it's very hard to keep patients' stories independent of our lives. The patient stories become integral part of who we are. And so, there are times where we discuss, whether it's a victory, a success story, or a sad story for the day. We do discuss, and actually married to an interventional cardiologist, it helps me tremendously because he's my sounding board on tough days, and I am for him.
So did you meet your husband as part of your in some point in your training?
Yes, I knew my husband quite young. I knew I was going to marry him. I chased him down, for lack of a better word. And, he dilly-dallied. He had, but during medical school, beginning first year of medical school, or maybe mid-medical school, we committed to each other. And so in New York, we settled down together. He was a resident at Albert Einstein, and I came in towards the end of medical school to do my postdoc research. So that's where, we said, fine, we'll get married.
So you chased him till he caught you.
Yes.
So how would you feel if one of your children decided to go into medicine? Or have they already had a
I'm good with it. I'm great with it. Medicine is a beautiful field. It's very gratifying. Yes, it has its ups and downs. What could we change? This corporate side of medicine, the revenue side of medicine, needs to go away. Physicians need to be their own leaders. We need to be our own leaders. We need to drive our show, because too much economics, where the empathy is buried down as a second or third level on the priority list, that is unacceptable. What is acceptable? Yes, finances are important. Yes, economics are important, but they need to be balanced, or empathy needs to be a bit higher, if I may, above the economics.
So, this is the $1 million question, or actually the multi-trillion-dollar question now is, so how do you think the payment for healthcare should be structured? And you started off by saying you didn't want to have a political conversation. And I agree with that, because I think many of us are tired of politics. But at the same time, we can't talk about healthcare and the delivery of healthcare now without entering into a political conversation. While you and I are taping this, while we're talking, the current administration is appealing to the Supreme Court to overturn the Affordable Care Act, which affects, probably 40 million people and the delivery of their health care, at least. It actually affects everybody, because most people don't realize that even if they don't receive their insurance through the Affordable Care Act, the Affordable Care Act sets standards that all other insurance companies also have to follow.
I know that's a great question, and as you know, the answers it's can be as deep or as superficial. But again, it's to make it not as political, I just feel like, physician leaders, I just feel like the healthcare delivery of healthcare needs to be led by physicians. We know what's best for the patients, and we need to have a voice, a vote in the boardroom, in the big rooms out there, and making these policies without involving us who take care of patients on day-to-day basis. It's just unacceptable. I mean, for the lack of a better word, it is wrong. It's absolutely wrong. What has that done to us? It's taking us away from why most of us went into medicine. The reason I went into medicine is because I just love taking care of sick people. There's no other layer to it. Well, do I make money by doing the job? Yes, just like every other profession. But do we think, okay, RVU, I'm just going to touch on the RVU model.
And tell people what the
RVU models are where you do a certain procedure, and if you use the certain codes, you get a payment depending upon what you code in your procedure. And so what does that do to a physician? What it does to a physician is, I look at a patient, I do a procedure, I start to think, okay, if I put an extra procedure in there, extra code in there, I can make more money. And a patient is not a number. A patient is a patient. They're sick. We just need to go do what's right by the patient. And there are pros and cons to it. I get it. But someone could argue and say, if you don't make it a productivity-based model, then do you have unequal distribution of the funds or the money? Yes, it's always going to be there. Find alternative methods to do that rather than just go by pure productivity-based models. So I just don't want us to get far away from patients where we look at a patient as a number and we start to look at finances every day, billing, reimbursements, and dictating for, someone else because they need to bill. I would just want myself to go to work, take care of my patients, listen to them, get my job done, and go home. And I want us to be the advocates for patients. Give us the chance. I don't think whether it's a corporate or the politicians have a big role in making healthcare decisions.
Well, I think it's also, there's a role for physicians to become politicians. And a few weeks ago, we interviewed Dr. Hiral Tipernini, who is running for Congress. So that's very exciting. We currently do have one woman who's already in Congress, one woman physician, if any more women.
No, that's a great point. That is absolutely a great point. I was just about to say that. I think when you asked me, do you want your children to go into medicine? Absolutely. So when I mentor a lot of students, residents, fellows, and I tell them, go into medicine, but I want you to become a physician leader. Get an MBA, know your finances, know economics, and also get into the leadership, like politics. That's where you have a powerful voice.
Right. And politics doesn't just mean on a state level or a national level. It also means on the level of your hospital board or the medical staff. So one of the questions I've been asking people lately, because so much of politics has infused every aspect of our lives, is if you were in a position, let's say you were head cardiologist for White House policy, advising, what would be the number one policy recommendation that you could make to either a state government or a federal government, just one, your favorite choice, that could really improve the way our healthcare delivery system operates right now?
Please take out the insurance companies. Take out the insurance companies to a point that they cannot decline a decision made by a physician. They cannot interfere with what we do. please take away the peer-to-peer phone call where a specialist is calling someone who does not do those procedures. And I'm trying to explain to them why my patient needs this procedure. Take all that out.
Right. And just so you know, every physician who I've asked that question to has given some variation of that answer. Although Dr. Sion Faru was very funny. She said, "Am I allowed to say we need universal health care?"
I know.
Absolutely.
Absolutely.
Especially in a pandemic.
Mm-hmm.
So I've also asked some physicians the question that if you were on the coronavirus task force, what is the number one recommendation you would make for how we can better handle the pandemic at this point? Obviously this question does not allow us to go back to February and say what we should have, could have, would have done in February or March or April or May that would change the death toll and the number of cases. But what would you recommend now, today, if you had that power to make a change?
Social distancing and protecting self and protecting others. I have heard people not wanting to wear masks. Please put on masks because there are people who are prone to getting this. If everyone is prone to getting this disease, okay? Anyone can get it. Young, old, doesn't matter, but we owe it to someone else. If you just, I'll tell you an anecdote. One of a patient and his family member walked into the clinic because some patients are doing face-to-face visits because they don't have access to technology, and that's totally allowed. They came in and they refused to wear a mask. So they entered the room, and as I entered the room, they took away the mask, both of them, and they said, this is all a drama created by physicians.
Aye.
It's not, there's nothing to it. So I told them, I just said, I'll give you 3 sentences of mine. And then if you still decide not to wear a mask, then that's your choice, but I refuse to see you. Because I need to protect my other patients and I need to protect myself too, and my staff. So one thing I said to him, it is not a drama. This is not a lie because I lost a family member to this. So I know this is real. People are dying. Number 2, I said to him, if you do not care about yourself and your family member, that's your personal choice. It's life is, that's your decision, but please do it to help your neighbor, your friend, your colleague who they do care about their health. So you have every responsibility to be a responsible citizen. And third thing I said is, think about it. The mask is very non-invasive. It doesn't hurt you, but a tube down your throat, if you do get ill, that does not feel good. And there's absolutely no dignity in that passing, if God forbid you are that person. So, and at the end of it, he did, whether willingly or unwillingly, but that's the truth and that's the reality.
Absolutely. What I always say to people who don't want to wear a mask is, how would you feel if you were having surgery and your surgeon said, I don't feel like wearing a mask? And of course, all of these myths that are circulating about masks, about how they increase CO2 intake and they're harmful for your health. And, those of us who were trained in surgery were wearing masks, without even, questioning it for, hours and hours and hours at a time. In those days, we had a new mask every procedure. So hopefully we'll get back to that as well. What are some of the other myths and misinformation that's circulating that really upsets you and bothers you?
With regards to the pandemic?
With regard to the pandemic or with regard to healthcare?
Yeah, healthcare. One of the patients actually told me she, alcohol and heart disease we've been through cycles. Do you drink, a shot of wine every day is okay and it's not okay? We went through cycles. It's still very debatable depending upon, but we know alcohol is harmful, So there's a patient just last week, the patient told me, hey, I drink a whole case of beer, and that's the reason I don't have heart disease. And I said, you have atrial fibrillation. And he's like, well, I have irregular heartbeat, but I don't have any blocked arteries. I never had bypass surgery, see? And and he was just telling me that science is useless, and he's a smart guy. But I told him, I don't want to see you back here with the liver cirrhosis or alcoholic cardiomyopathy. So just stop drinking. And he's an intellectual. He owns his own business, and so think about the myths that go through the in people. And then this taking herbal supplements to try to kill everything. And I don't even want to talk about the Lysol in getting rid of.
And bleach. I actually heard a woman comedian who said she asked a guy, one of the guys in the audience said, she was talking about supplements, and one of the guys said he took zinc. And she said, oh, does it work? And he says, oh, about half the time. And she says, what do you mean it works half the time? He says, well, about half the time I feel like getting up out of bed in the morning, and half the time I don't. And she said, that's a lot of pressure to put on zinc. But yes, everybody has their theories. But now's a good time, actually, speaking of that patient who said, well, I have an arrhythmia, but I don't have heart disease. Explain to people what heart disease is. When we talk about coronary artery disease, and we use the terms coronary artery disease and heart disease and atherosclerosis, and we kind of sometimes use them interchangeably, and I think people are very confused. And then when they have an arrhythmia, that's very scary, because your heart can stop, or your heart can, just stop pumping effectively, but they don't understand why that's not heart disease. So sort that out for people.
Great. So heart disease comes in many forms. So think about the same analogy I gave before, where the heart is like a home. So if the doors, even if you shut the doors, and the doors, for example, are not closed effectively, then the air starts to leak. Similarly, in the heart, if the valves do not close completely, there's regurgitant, where the blood flows back into the receiving chamber. And or if the doors are tightly shut, where you can't open them and you really need to pull, you don't get enough air into the room, and that's nothing but stenosis. Stenosis is a closed valve, or the doors where the blood doesn't flow effectively. So a valve disease is one component of heart disease. Second thing is the plumbing disease, where there are three main arteries that go down the heart, give blood, and if there is any blockage because of cholesterol buildup, or a rupture, or a spasm of the blood vessel, which is seen in women more often, that can lead to lack of blood supply, and which means low oxygen, which means a dead heart muscle. So the heart muscle gets weaker. And the electrical problems, which I discussed before, whether it's an extra nerve or a split nerve in the heart, or lack of heartbeat, the dominant pacemaker deciding not to work in the heart. And so all these components are heart disease. Everything is heart disease. So when patients go to talk to their physicians, they need to find out, do I have a blockage in the artery where I need a stent or a bypass surgery? Am I at a risk for having a heart attack? Or do I have a leaky valve? If so, can I be on the right medications? And I'm at a risk for having heart failure, where the pump is failing to effectively pump the blood forward. And if so, do I need surgery for the valve? Or do I have an electrical problems where I need to see the electrophysiologist?
And you can also have a combination
of everything.
Multiple things.
Yes.
But what you also referred to about this gentleman who's drinking a case of beer every day, if he developed a cirrhotic liver, that, of course, in and of itself could also lead to risks elsewhere. So I love your analogy of the home, because we could play with that all day and talk about, how all the body parts interchange and affect things. Now, when I was talking to you about coming on the show, and I'm really glad that you did, I asked you what you were passionate about. And what I loved is you gave me a whole list of things that you were passionate about. So I do want to give you a chance to talk about that. And of course, we're mourning the loss of Supreme Court Justice Ruth Bader Ginsburg this week. And she shared a very important passion with you, and that's gender equity, which you put on first on your list. So what are the things that you're concerned with about gender equity, both in medicine and outside of medicine? And, what are the things that you really care about explaining to our listeners?
Yeah, I'm going to start off with Fortune 500 companies. I don't know if you looked at it, CNN had, and everywhere in the news last year, they declared that we are at the highest number of gender equity in Fortune 500. And if you look at it, the number of CEOs that are in the Fortune 500 companies are only 37. And what does that?
So 37 women
37.
out of 500 companies are CEOs.
Yes. So that boils down to 7%, 7.5%. So we're still not there yet. That by any means is not gender equity. Women, we need 50%, or like
52% actually.
Or yes, at least 50%, or like RBG said, why not all? Like
right.
In the Supreme Court justices, why not?
She was asked what the optimal breakdown of men and women on the Supreme Court would be. And she said, we should have 9 women. And the person who asked her was shocked and said, all women? And she said, well, for 250 years, we had all men. And how well did that work out?
Absolutely. And so we are not there yet. Yes, are we making progress? We are, but it is a very slow progress. So I've just wanted to give one of the statistics out there for the audience that, that's in the business world. Now, let us take that into medicine, and Association of American Medicine, which is one of the associations that collects data for medical colleges, and how many women are chairs of the divisions. In internal medicine, 17% of the women are chairs. So rest of the chair positions are occupied by men. So that is, again, we have long ways to go. We have a lot of work to do to see more women in power, in leadership positions, in the decision-making platforms. We need more women in the boardrooms making decisions. We are okay. We were the sheep all these years, and that's okay. But I think it's time to be the lions.
Well, and be more prominent in leadership positions. We were fortunate to have one of our previous podcast guests was Dr. Mary Lake Polan, who, as far as I'm concerned, having trained in OBGYN, is a rock star in OBGYN because she was the first woman to be the chair of a OBGYN department in a major academic health science center. She was the chair of OBGYN at Stanford. She was also on the board of directors of American Home Products, which was the owner of Wyeth Pharmaceuticals, among many other companies. So a real rock star. But we also had 2 women physicians as guests in past episodes who are orthopedic surgeons, Dr. Nancy Yen Shipley and Dr. Alexis Cheng Colvin. And it turns out that among orthopedic surgeons, not the leadership, not the chairman, just orthopedic surgeons, only 6% of orthopedic surgeons are women.
And, cardiac electrophysiology, it's the same story. Our field, we are close to about 7% now. Mm-hmm. So only 7% of all cardiac electrophysiologists are women. And you mentioned it in my bio that I'm the first woman to join the Texas Cardiac Arrhythmia, which is the largest private practice EP group in the country, and they're all men. And I broke.
How many physicians are how many electrophysiologists are in the group?
It's a big group, but in Texas we have 11, but all over the country we have more EP physicians in North Carolina, Kansas. So it's a big group. close to, I would say, about 22 or so, and I'm the first one. So,
well, congratulations, and
thank you.
very exciting. So tell us some of the other issues that you're passionate about.
Passionate about, same gender equity is one thing, so people ask me, what are the few things we as women can do we as a society, as a structure, can we do to bring more women to the platform? And the platform has to change at home, in the community. That's the step one. How is that going to affect us in the leadership? Well, daily responsibilities at home, daily chores, they need to be divided. And women need to be their own advocates, ask, delegate, communicate, and get help. And as far as the system goes, the other thing I'm very passionate about is the implicit biases. We need to undo those biases. What are implicit biases? I'll give you an example. So my first job, I had great colleagues, wonderful experience in Ohio. But when I started the job, one of the physicians who interviewed me asked me, so you're going to have children, you're pregnant, then we need to start looking for someone else while you're pregnant and off, or how many days are you going to work right after you have the baby? I said, well, I'm going to take my good 3 months of postpartum leave. And during that time, I won't have my pager. You cannot reach me. And during pregnancy, the third trimester, I'll try to do procedures, but I will be too big to reach the table. So, I'll request to be put in the clinic. And so communicate, ask, we need to ask. And people on the other side of the table have a bias saying, oh, because she has kids, maybe she won't be interested in a leadership position. Because she has something else, she might not be interested. And that's an implicit bias that does affect gender equity.
Right, because
negatively.
they would never think that of a man who had children.
Mm-hmm. Yes, yes.
I'm from an era where it was still quite common and quite permissible during interviews for medical school and residency to ask about your plans for having children. And I just was thinking so hard, like I need to have a humorous way to deal with this. And the question was usually phrased like, what would you do if you became pregnant during residency? So finally I came up with something, and a doctor at the University of Rochester asked me that question in the interview. And I put on a shocked facial expression and I was all prepared. And I said, but I'm not even married. And I think he wrote down, too naive to be an OBGYN residency.
Oh my God. Oh, that's, so the other thing is the same layer, and switching to what are my other passions is the physician's wellness and women empowerment. The EQ, emotional intelligence, is a talent and we need to tap into it. Why is that so important? It plays a role in physician wellness. It plays a role in gender equity. It plays a role in women empowerment. Self-awareness is such a key. Knowing what you want, prioritizing life, and living life in stages. It's okay to hibernate when you need to hibernate. It's okay to take it easy and take the back seat, someone else be the driver. That does not mean we lost the goal at any point. We'll still get there. It's not a race. And I usually tell myself and tell my mentees that you need to be unique you. Write it on a wall every day if need be. Say, I am myself. My priorities are different from someone else's. My talents are different. My goals are different. And because if you don't do that, it leads to burnout. It also leads us to imposter syndrome. All of us have imposter syndrome at some point where we feel like, maybe I don't know as much as I think I know. Maybe I'm not fit for this job or something like that. But to tone down or keep that imposter syndrome down, that self-awareness and that self-confidence from within is such a key. And how do we get there and how do we balance? It's much more important for women because we have children, their health issues, their appointments, their homeworks. And as physicians, we have our patients to care for. And tapping into yoga, exercise, meditation, and having a hobby, whether it's art, music, our group of wonderful friends. And the last part of that is just saying no to the naysayers, keeping the negativity out. Absolutely. Always be kind, empathetic to self and others, and, lift whoever is not as fortunate around you.
What I've often said is treat yourself at least as nicely as you would treat a total stranger.
Absolutely. Absolutely.
So we did have a whole episode on imposter syndrome with Dr. Jennifer Hunt, who is a department chair in pathology, as well as a physician coach. This issue of physician burnout, of course, affects all people, because if you see a physician as a patient who is suffering from burnout, you're not going to get, the optimal care that you would. And so this is also a societal issue. What I have often said to medical students and mentees is that, yes, you can do it all, have it all, and be it all, just not at the same time.
Same time. RBG.
Yes. Well, and if we look at Ruth Bader Ginsburg, she was a phenomenal example in this regard as well. She went to Harvard Law School at a time when I think she said there were 7 women in the class of 500, or 9 women in a class of 500. And she said that they were invited to the dean's home for dinner. And he asked each one of them, why do you think you deserve to be here, having taken the place of a man? She actually did become pregnant in her first year of medical school. She was married, and her husband, who was 1 year ahead of her in law school, developed a pretty severe testicular cancer at that time. So she was taking care of a husband with cancer, helping him stay up to date with his classes, taking care of a newborn, and she made law review, which is pretty spectacular.
Yeah, I tweeted the other day about RBG. What stands out is beyond her, her sayings or the quotes. New York Times had a beautiful article on her where she, and the NPR too, where she thanks her father-in-law, her husband, her mom, and her colleagues. She's a very a person who has so much of gratitude and just balanced her life. I mean, she actually says in that up until 4 p.m., it's law school. After 4 p.m. until the kids go to bed is my kids' time. And so she balanced it all, and she's such a great role model for all of us.
I think that's what I found when I became a mother, is it made me much more efficient and much more organized, because I had no choice.
Yes.
I had to be much more structured and much more well organized. And that's the only way to do it. So anyway, I could talk to you all day about, these kinds of issues. And there's so much more to cover. But before I let you go, I have to ask you what your most unique, interesting, or memorable experience was that you ever had in a ladies' room. Other than this interview, of course.
Let's see. Okay. We were trying to get pregnant. Okay. Married to an interventional cardiologist who is on call every third night. And I'm on call. I was in Ann Arbor training, and he was in a border of Ann Arbor, Michigan and Ohio, 45 minutes south. So during, obviously, just like any woman, you keep an eye on your ovulation. And I still remember I was on call, and I was ovulating, and I was like, oh my God, I'm beyond 30. I need to get pregnant. So I called him and I said, I'm ovulating. He's like, what do you want me to do? You want me to, well, this is fine. I'll just say it. You want me to ship some sperms in FedEx? What do you want me to do? So that's the life of, whatever, life of dual physician families, or maybe it's true for many people where the spouses are traveling and you're stressed that you're beyond 30, you need to get pregnant.
So how did you connect that to the ladies' room? So what did you do?
Well, you just wait out, and the next, there's nothing I could have done that night, but next day, yes, you get back to work and get back to home and, work on getting pregnant.
Yeah, when I was trying to get pregnant the first time, my husband and I were both in jobs where we were traveling a lot. And so it took a lot longer than we had planned. And I think that's one of the things I also tell women, who are in medical school or other careers, is that, the saying about people plan and God laughs. We think we can plan our fertility so that, when you finally decide that it's a convenient time to get pregnant, or that you're ready, or you finished your training, or whatever marker you set for yourself, then you have to actually conceive.
Mm-hmm.
And we don't think about the logistics,
Absolutely.
that if you're married to somebody who's also in a high powered position and you're traveling or you're on call and your call schedules don't match up. And of course, when I was trying to get pregnant, it was in the days before ovulation kits and ovulation predictors and computers and apps and all those things. So my husband used to joke all the time about, there's only one thing FedEx doesn't deliver. And as far as I know, they probably do deliver that now.
Probably.
Anyway, it's been such a pleasure speaking with you. I wish you every continued success and health, and certainly to your children. And we will stay in touch on Twitter. Tell people how to find you on Twitter.
We were just tweeting and tagging each other. And there was another speaker, I don't know if she made it to your podcast yet or not, someone who was a physician who went into Hollywood or some
she's a music producer, Dr.
Music
Candace
producer.
Williams.
Yes,
she was a guest in our podcast a couple of weeks ago.
Oh, wow.
And she is as fabulous and interesting as you can imagine. We love talking to women who've done, unique and different things, or traveled the paths less traveled. But I was asking you for your handle on Twitter so our listeners can follow you.
It's K Tamirisa MD.
Okay. Great. Anyway, thank you so much for joining us. We really appreciate it. And we will look forward to seeing you in the Twitterverse, and keep fighting all the good fights and addressing all of your passions and inequities. And hopefully we will continue to make progress.
Thank you so much. You have a wonderful day.
Thank you. Take care.
That's all we have time for today. But let's keep the conversation going on Twitter or Facebook at Dr. Donnica. And please join us next week for another episode of In the Ladies' Room with Dr. Donnica. Real conversations with real women about really intimate topics.